Hello, everyone. Our group will be presenting on autism spectrum disorder, also referred to as ASD. This presentation was created by Kerrigan, Noah, Johan, and Josie. ASD is a complex condition, and our goal is to provide a clear overview of how it is defined, how it presents, its impact, and its connections, both on students and general daily life, in addition to how other diagnoses that are comorbid impact the individual as well. Defining autism spectrum disorder, or ASD. Autism spectrum disorder is a neurodevelopmental condition that impacts how people communicate, behave, engage, or disengage in interest and interact socially. One important concept to understand is that ASD is a spectrum. No two individuals are exactly alike. There are wide variations in individuals' experiences and forms of expression. The DSM-5-TR outlines several criteria including these key points: persistent social communication and interaction challenges, restricted and or repetitive patterns of behavior, early onset, early in development, significant impact on daily functioning, including social, occupational, educational, and other important settings and areas of functioning, and importantly, the symptoms aren't better explained by an alternative condition. This definition highlights how ASD affects multiple areas of development and daily life. The severity of ASD is broken down into 3 levels. According to the Children's Hospital of Philadelphia, ASD's 3 levels of severity scale is defined as Level 1. Individuals may have difficulties initiating conversations and struggling with flexibility or adaptability, but can function with some support. Level 2, there are more noticeable verbal and nonverbal social delays, limited ability or interest in initiating social engagement, and repetitive behaviors that are more obvious, resulting in higher distress when interrupted. These individuals often need substantial support. Level 3. This level includes severe communication deficits, very limited social initiation or response, extreme difficulty coping with change to environment, or interruption to behaviors, and high distress when routines are interrupted. These individuals often need very substantial support in daily life. It is essential to remember that severity isn't static. Support needs may change over time or with the right intervention. It varies based on the individual. Again, it's a spectrum and it is not a one-size-fits-all hat. The presentation of ASD can present in multiple ways. As it pertains to socially, we may see a delay in head nodding, limited facial expressions, or trouble sharing emotions. There may be difficulty forming friendships or expressing feelings. Behaviorally, we may see signs of repetitive stereotypes or restricted behavior surrounding interests or activities that can include hand flapping or repetitive motions, extreme reactions to change in routine or environment, unusual responses to sound, texture, or light, a strong preference for rituals or routine that, when disrupted, create feelings of frustration or overwhelming feelings of frustration, and then frustration with expressing feelings. Interestingly, around 80% of children that later have or currently have an ASD diagnosis show signs of ASD before the age of 2 years or 24 months old. So early observation is key when assessing for autism spectrum disorder. As to the prevalence and impact, in the United States, 1 in 44 children has an ASD diagnosis. Globally, that's about 1 in 160. As noted by Hirota and King, the global impact is presumed to be higher or lower, but is influenced by the lack of, the global impact is presumed to be higher, but is influenced by the lack of resources in healthcare that are accessible and available. Further, the lack of advancement of modern medicine or differing cultural norms may impact how mental health conditions are diagnosed. In the United States, there's a notable gender difference. About 1 in 23 boys versus 1 in 88 girls in the United States have an ASD diagnosis. However, research suggests that often girls are underdiagnosed, possibly because of their symptoms and how they present differently. Another key issue is the racial disparity. Black and Hispanic children have a higher diagnosis rate than white children, which raises important questions about our healthcare system, access, and medical bias. We must ask, who is the medical system built to serve? And this reflection can help push us towards equity in diagnosis and treatment. In some areas of the United States, where access to affordable health care, or adequate health care for that matter, is much more limited, impacting minority communities, we may see higher rates of diagnoses for a lack of resources and testing available to more affluent regions of the country. Comorbid diagnoses and considerations may surround mental health conditions such as ADHD or attention deficit hyperactivity disorder, anxiety disorders that can surround presentation of social anxiety, separation anxiety, or generalized anxiety, depression, obsessive compulsive disorder or OCD, and in fewer cases, but still with a correlation, bipolar disorder. Neurological and physical conditions may consider epilepsy, sleep disorders, gastrointestinal issues, developmental coordination disorder or DCD, and other considerations may include intellectual disability, sensory processing issues, or Down syndrome or Fragile X syndrome. Recognizing these co occurring conditions helps professionals develop a more effective and personalized support plan for each individual. So far, we've laid the groundwork by defining ASD, discussing how it's categorized, how it appears, its prevalence, and what other diagnoses often come with it. Next, we'll explore how it's assessed and what it means and implies and impacts for an individual in the educational setting.
So, when we're talking about the etiology or the causes of ASD, we find that there's no single cause of ASD that's known, but a combination of a variety of factors like environmental, biological, and genetic factors. So, with the complexity of this disorder, we don't really know exactly one thing that might cause ASD, but we can look into risk factors that might heighten the chance that a child develops ASD and therefore look further into those risk factors in order to proceed with screening and diagnosis. So, some of those risk factors might include siblings with ASD, so having familial ties to the disorder, genetic or chromosomal conditions, birth complications, so if someone was born prematurely or if there was an incident at birth where the child was deprived of oxygen to the brain at any point, or any other sort of incident with their oxygen during birth. We also have prenatal complications, so if they were exposed heavily to pollution, or if the mother herself had any complications such as maternal diabetes, and also we have older parents. So again, this is not an exhaustive list, but these are just some of the main factors that they might look into when looking to screen for ASD and later diagnose ASD. There's also a lot of misinformation around what causes ASD. So I'm sure a lot of people have heard about the supposed link between ASD and vaccines, but we find that there is no real evidence-based link between ASD and vaccines, and a lot of that theory is based around a retracted 1998 paper with cherry-picked cases of children who did receive the vaccine and later found that they had autism, but there is no true connection between the two. There's no true proven connection between the two because it was just basically a lot of coincidental cherry-picked cases. And so a lot of studies surrounding the topic since then have not shown conclusive connection between the two, and therefore we do not see any real evidence of that. And so when assessing for ASD or determining eligibility, where do we start? So it starts with developmental monitoring and developmental screening. So developmental monitoring is something that doctors will do for pretty much any child, not just ones that they think are high in risk factors for ASD. It's a pretty standard practice for doctors when they're seeing children, but it's basically that they inquire about the childhood behavior, milestones, and other aspects to ensure normal development. So, is this child saying their first word at the rate that their peers are? Are they walking at the same rate that their peers are? Basically, ensuring that milestones are being hit on pace to make sure that the child is keeping up with their peers in that aspect. Next, we have developmental screening, which is something that, again, most children will go through, and it is slightly more formal than developmental monitoring because doctors may ask parents to fill out a questionnaire about the child's skills, including language, emotion, and social skills, and other aspects. So, again, this one gets into a bit more specifics, and the parent is a little bit more involved in having to actually fill out the questionnaire. And we also want this screening to occur at regular intervals. So at 9 months, 18 months, 30 months, and even maybe more consistently if there are multiple risk factors that are present. But basically, the screening is just really important for early intervention and being able to diagnose early. And here we have a flowchart for what the doctor might do depending on the outcome of the screening and what their concerns are. And that's basically just a process that they might follow depending on if the child screens negative or if they screen positive. Next, we have assessment tools in ASD. So, what kind of screening tools might we use to screen children for autism? So, we have the Ages and Stages Questionnaire, or ASQ, the Communication and Symbolic Behavior Scales, or CSBS, Parents' Evaluation of Developmental Status, or PEDS, Modified Checklist for Autism in Toddlers, or the MCHAT, or the Screening Tool for Autism in Toddlers and Young Children, or the STAT. And there are more screening tools than this. This is not the exhaustive list of all the screening tools that are used. These are merely a few examples. So some of these tools are questionnaires, like we said, the parents fill them out, while some are more interactive tools, so they might have the child do certain tasks or observe them in a certain environment that hope to observe the child's natural behavior. And when selecting a tool, the physician might have multiple considerations in mind, such as specific concerns with the child. So, what milestones are they hitting? What aren't they hitting? What are the parents' most prominent concerns with the child's development? The condition target. So, are we really suspecting ASD at this point? And if so, are we targeting to really test for that? The sensitivity of the tool and the setting in which the tool will be administered. Finally, we have diagnosing ASD. So again, without one root cause, diagnosing ASD can be a bit of a complex process because there's no one true thing to look for when you're looking to see if someone has ASD. And so, with that in mind, the diagnosis is based around the child meeting standardized criteria from the DSM-5. So they have to meet multiple criteria from the DSM-5 in order to be considered for ASD. And multiple professionals might be involved in this process, such as neurodevelopmental physicians, child neurologists, geneticists, and other experts in their fields. So, according to the US Centers for Disease Control and Prevention, to meet diagnostic criteria for ASD according to the DSM 5, a child must have persistent deficits in each of three areas of social communication and interaction, plus at least two of four types of restricted repetitive behaviors. And so all of these deficits and behaviors are listed in the DSM 5, and the physician would work closely with the parents to sort of point out which deficits or behaviors that their child might have, and therefore check those off in the DSM 5 to see if they would qualify to be diagnosed with ASD. In addition to these behaviors and deficits, the symptoms that the child shows must also be present early, cause significant functioning impairment, and not be easily explained by other delays or disabilities. So, if they're more generalized symptoms, they might not count towards the actual ASD diagnosis, and the doctor might look elsewhere for other diagnoses.
Spectrum disorder, or ASD, presents through a range of behaviors and sensitivities. Some common characteristics include intense reactions to sounds, smells, tastes, textures, lights, and/or colors, resistance to minor changes in routine or surroundings, delayed language development, loss of previously acquired speech or social skills, persistent repetition of words or phrases, difficulty understanding other people's feelings, avoidance of eye contact, persistent preference for solitude, restricted interests, and repetitive behaviors. As you can see, these characteristics, like sensory sensitivities, resistance to change, delayed language, and social challenges, don't just exist in isolation. They also affect several areas of a person's life, especially for the students. So they can affect them academically, socially, regulating emotions, daily living skills, and many more. Academically, language delays and echolalia can make it hard to follow verbal instructions. Students may also struggle with transitions between activities due to their strong need for routine. This can impact their performance, especially in language-based subjects. That being said, many excel in structured areas like math or science, where routines and memorization come naturally. Socially, avoiding eye contact or struggling to read emotional cues can make it difficult to form connections with teachers and peers. Without support, these students may experience exclusion or even bullying simply because they communicate or engage differently. In terms of behavior, repetitive actions like rocking or hand flapping can help regulate emotions but may also distract others or interfere with focus during class. Recognizing this helps us create more understanding and inclusive learning environments. And finally, when it comes to daily living skills, many students with autism have difficulty applying routines learned at school to other environments like home or the community. This makes generalization a key focus in helping them build independence over time. Some additional information about ASD. I found resources from Autism Resources for Parents through the Lighthouse Autism Center, Autism Resource Center through the American Academy of Child and Adolescent Psychiatry, and Autism Classroom Resources. The first one I'm going to talk about is the Autism Resources for Parents through the Lighthouse Autism Center. It gives resources for the parents and caregivers for training that are personalized, insights, frequently asked questions, and insurance guidance. Detailed answers about Lighthouse's ABA fusion therapy model, addressing common questions and concerns. Lighthouse also assigns a dedicated insurance and specialist to support families in understanding coverage, filing claims, and identifying available grants. And they also include regularly updated blogs offering practical advice and insights to guide families in their autism journey. A couple more resources they offer are external sources where they have practical tips as well. And then lastly, they have a family outreach team where a dedicated contact team is there to answer questions, provide access to resources, and connect you with the appropriate support within the Lighthouse. The next resource is the Autism Resource Center through the American Academy of Child and Adolescent Psychiatry. They have Facts for Families, where there is concise, free downloadable guides written for parents and caregivers. Educational videos that help parents and children understand autism and support their needs. Experts, where they do Q&As and then also frequently asked questions, which are featured responses from child psychiatrists on topics like medication timing. And they help parents understand when and how to involve professionals and decide on treatment plans. Lastly, for this one, they also have additional tools like Psychiatrist Finder and training videos. The last resource I have is the Autism Classroom Resources, where they offer free resources like PDFs, webinars, and videos aimed at boosting classroom and home learning. Practical teaching materials, where they have ready-to-print and digital tools to help classroom functions like behavioral data sheet packets. Classroom setup and design guidance, where they offer comprehensive floor plan examples. And then podcasts and blogs. They have over 240 episodes offering short, actionable advice on behavior management, communication, routines, data collection, and educator self-care. And their blogs are around reading programs, social stories, classroom missions, IEP data, spring and summer activity guides, and distance learning tips.
Moving on to suggestions for the classroom. So what should teachers know about students with autism spectrum disorder? Students with autism spectrum disorder often exhibit difficulties with executive functioning skills, and this can look like difficulty with managing tasks, planning actions, and controlling their impulses. They may also have difficulties with social interactions with peers, and this can be their classmates or also adults. They may have difficulties with working memory, so this would be the ability to retain short-term information. Also, they may have difficulties with the theory of mind, and this is the ability to think about and understand what another person is thinking. Those on the autism spectrum may also have difficulties with changes to external stimuli. So this may look like a change in the seating arrangement in the classroom. If there is a new staff member that is entering the classroom to work with this student and or the whole class, or if a current staff member is now leaving the classroom and going to a different job, this may also cause difficulty for a student on the autism spectrum. They may also have difficulties with changes to routines and expectations. So it is important for teachers to have clear expectations and also consistent routines. Those on the autism spectrum may also have difficulties with language and communication. This means that students can range from nonverbal all the way to verbal. Those who are nonverbal may use an AAC device or other communication tools. This is something that looks different from student to student and can vary based on age and severity of their autism diagnosis. Additionally, students with autism spectrum disorder may have sensory issues. Teachers should be aware of how noises, smells, the surface of objects and food, and how taste may affect their student. For example, a student may be upset about how loud gym time is because the noises are bouncing off the walls, and that can become overstimulating for them. Additionally, those on the autism spectrum have special interests sometimes. So this can be used within lessons for students to become more engaged, or their specific special interests can also be worked into a reward system that is used within the class or with a specific student. And I've noted here at the bottom that each student diagnosed with autism spectrum disorder will present differently. As we've learned above in previous slides, autism occurs on a spectrum. This means that the notes I have provided does not account for every individual who presents with autism spectrum disorder. So I have included 3 instructional strategies for teachers to implement when working with students on the autism spectrum. So the first thing I've included is peer-mediated instruction and intervention. So this is an evidence-based practice where peers serve to support the academic and social skill development of students with specific learning needs, including those with autism spectrum disorder. This involves the recruitment and training of peers without disabilities to model and reinforce academic and social behaviors in the classroom. This can allow for general education access for students with significant disabilities, and this can also be beneficial in large group classrooms because it allows for direct feedback from peers. Students with autism spectrum disorder will likely benefit from structured and predictable class routines. However, variations in class structures across different classrooms and with the additional aspect of having large classrooms which can mean that the teacher may not be able to provide feedback immediately. So having this peer-mediated instruction may help with that initial reinforcement and prompting that a student with autism might need. And I've included down here an example of what an activity schedule may look like for a peer who is working with somebody on the autism spectrum in class. So if you're interested in learning more, there is a couple links located in our reference section about peer-mediated instruction and intervention. The second instructional strategy I've included is the visual immersion system. So this focuses on using engaging visuals to increase language, and I've provided a video as well that does a pretty good job of giving you a baseline into what this could look like in the classroom.
Give the marker.
Give the marker. Give marker.
Give the marker.
All right, so one of the goals of the visual immersion system is to improve the learner's independence and reduce some of the frustration that comes along with communication. And the VIS does this by using clarifying visuals. And as we saw in the video, there are different types of visuals that can be offered to learners based on their preferences. So again, very baseline with this. We have links in our reference section. And then our last instructional strategy is concurrent chains preference assessment. So for short, this is called the CCPA. And this allows for students to provide input about their interventions that they receive in the classroom. So similar to a preference assessment, there's different types. With this one, students get to pick their preferred behavior change procedures for instructional contexts, which increases the social validity of the instruction. This can be used to gauge reinforcement parameters, instructional procedures, and choice considerations. So there's 5 objectives with the CCPA. So the first objective is to identify context or activities. So the teacher should be able to identify a small number of activities or contexts for assessment. And the purpose of this is to identify the contexts or activities so that we can assess students' preferences for each of those and eventually be able to embed those highly preferred contexts into the daily instruction. So objective number 2 is to identify signals. So once the teacher finds the context, they will also identify unique and distinct signals that vary on one dimension, such as colored cards or tag boards. And the purpose of this is to provide the student with something that's tangible, that's compared with each context. So a signal should be a tangible way to identify a specific context. And then moving on to objective 3, this is to learn associations. So the purpose of this is for the student to learn the association between the signal and the context through multiple teaching trials. And then number 4 is to describe associations. And this is to ensure that the student has learned the relationship between the signals and contexts. So this could look like the teacher asking the student to describe the context that corresponds to each signal. And then lastly, we have objective 5, which is to indicate preferences. So the purpose of this is to identify the preferred and non-preferred contexts through assessment trials. And the assessment trials are the same thing as teaching trials, so that would look like objective 3, which is in the learning. And then when they do this objective 5, that's kind of to get what the student prefers. And again, this is very brief, and we have additional information in our reference section, which is here. And then we also have more down here. So we thank you for listening and hope that you were able to gain some new information.